anaerobic infections, you're talking about really serious, sometimes fatal infections. When, especially if like they're opportunistic or they're in the hospital and they're secondary infections. Okay. Thanks for leaving me. All right, guys. Remember on these, we've done these before. You want to review these and the oxygen levels of the tubes, okay? Because that will come up on the test. Like draw me a picture or whatever. All right, but most of the time the organisms clinically are going to fall into air-tolerant anaerobes. And they're not going to be able to perform metabolic processes unless they're placed into an anaerobic environment. So that's our good old Thio Fluid, okay? The other thing is that molecular O2 can be toxic to some of the anaerobes, okay? Even some of the metabolic processes that O2 produces can be toxic to them as well. For example, they can lack some of the protective enzymes such as catalase. So this is like just an example of how it can be toxic to them, okay? Now, where are anaerobes found? They're going to be found on the inside of the body and the outside of the body. And one that's particularly difficult to deal with, and it's very common, is Clostridium difficile. Okay? That one, Marianne, you see that one probably a lot, right? In the hospital or wherever you're. Yeah. So antibiotic acquired most of the time. Diarrhea, it's pretty bad. And the diagnostic test for this one, it's usually based on the detection of the toxins that it produces. Okay? So endogenous microbiota and exogenous anaerobes. So two different ones there. That's pretty self-explanatory though. Okay, just a picture of Clostridium. And then I gave you guys up here just the common sources of anaerobes. So I would be familiar with most of those names. Okay, they're not in the PowerPoint. You don't necessarily need to go into big detail, but just know that these are like the main players right there. Okay. Okay. So anaerobes at specific sites. So skin. If you have an abscess, the specimen on the skin needs to be aspirated by a needle, and it's much better than a swab. Okay. Respiratory, you're talking saliva and nasal washings, 90% of those are going to be anaerobes. The GI, any infection in that cavity would be likely to be caused by organisms that escape the GI tract. And then you have the GU, 50% in cervical and vaginal secretions are going to be anaerobes, which is pretty interesting. In the GI tract, you're mostly looking at the very first one that I have up here under common sources, Fragilis. Okay, that would be an example for the GI tract. Let's see. Factors that predispose patients. All right, we already talked about this, about the trauma, particularly to the skin. It's going to let endogenous biota gain into deeper tissues, which is the problem. Okay, vascular stasis, preventing oxygen from entering a particular site. And then if you have decreased oxygenation, that's when you're going to start dealing with stuff like necrosis. Okay? So any questions on that one? Pretty good so far? Okay. Indications of involvement. Infection, usually close to the mucosal surface. Again, presence of a foul odor. That's usually like one of your go-to things. The brick red fluorescence is on there. Sometimes you can have a large quantity of gas, if you think of gas gangrene. Sulfur granules, and then they have sometimes distinct morphological characteristics in the gram staining. Okay? So they're a little bit different than like your just typical gram-positive and gram-negative bacteria. Okay. So this would be the list of basically the frequently encountered anaerobes and their associated diseases. Okay, so you have gram-positives, and then you have anaerobic gram-negative bacilli, and then just anaerobic cocci. But we're going to go into more detail about these. So the first one I want to talk about is Clostridium perfringens. This one is really associated a lot of times with contaminated food. like people that can things and they don't can them properly and it's not under the correct pressure or temperature, that can happen and you can get an infection that way. So you have the foodborne disease, which is type A, okay? And that one's linked to sporulation. And then you have type C, which is enteritis. Okay, so make sure you know the difference between type A and type C. Okay? Let's see. Gas gangrene and bacteremia, those are examples of what this bug can do. And most of the time it's associated, like I said, with contaminated food, but a lot of times with meats and gravies of all things. Okay? And you can get massive, massive food poisoning from this. The other thing too is that type A is pretty mild and self-limiting versus type C. You're talking that it's rare and serious. Basically you get inflammation of the small intestines and it's necrotic. That's what's actually happening. And it will become fatal without treatment for type C. Okay? Then you move on to, there's a picture of it right there. Then you move on to botulism. So that's actually ingestion of the botulism toxin, which is also produced in food. Toxins A, B, and E associated with human infection. They use actually type A though for Botox and also what's called the wandering eye syndrome, where you have one eye that's going that way versus the other one that has normal vision. But this is what they're using for Botox, is type A, okay? And this one is canned vegetables and meats and preserved food. The thing that's scary about this one is the neurotoxin that it produces. So basically, it's going to prevent acetylcholine, which is going to result in paralysis. So if you don't have that, it's going to be paralysis. And then if it does it in the respiratory system, that's when you're talking about death, okay? Whoops. And these are the clinical manifestations right here, okay? Blurred vision, impaired speech, difficulty swallowing, and that's where I'm talking about the respiratory paralysis. And then also what they would do is give, if they can, an antitoxin and or supportive care for that. There's also what's called wound botulism as well, okay? All right, tetani is your next one. This one also neurotoxin. This prevents release of neurotransmitters. So you have spastic paralysis with like muscular spasms all the time. This is a result of spores in the environment. If they enter the skin through a puncture wound, that's why they're always talking about if you step on like a rusty nail or something like that, go and get your tetanus shot. But it is prevented by the DPT vaccine. And then the therapy would be an antitoxin, muscle relaxants, not a bad thing, and intensive therapy to help you out, okay? Difficile, we just talked about this one. This is the antibiotic-associated diarrhea, okay? You have a toxin A and a toxin B. So know the difference between these guys. That one's an enterotoxin and one's a cytotoxin, all right? And again, this is a nosocomial infection, very, very common in the hospital. Just another picture. All right, these are going to be your gram-positive non-spore anaerobic bacilli, just right here. So you need to know these three. So on our first one, this is going to do chronic granulomatous infectious disease. I totally said that wrong, but development of sinus tracts. This is where you get the sulfur granules, okay? Wet mounts are usually useful for this one, okay, in terms of identifying it. And it's considered part of endogenous flora, but it's also considered opportunistic as well, okay? In females, for the female genital tract, you usually have this infection, and there's a problem with this associated with IUDs. You know, does everybody know what I'm talking about? Intrauterine devices, yeah. There's been connections with this one and IUDs for whatever reason, which kind of can I don't know, has anybody ever had an IUD in here? No? Yes? Did you ever have any problem with it? No? I did. I had to take it out. It was awful. So I don't think it had anything to do with this, but it just was painful. All right, bacterial vaginosis. Okay, we talked about this one briefly before. So you're shifting basically the pH in the vagina, okay? And you're talking about a vaginal discharge. There can be little or no discomfort and no inflammation, so some people will have this and not even realize it. But most often it's going to be diagnosed on clinical appearance of the gray-white vaginal discharge and then a gram stain of the vaginal secretion, okay? And the one that actually plays a role in this is the Lactobacillus. This one, what you need to know on this is that colony morphology varies greatly, so it's highly pleomorphic, okay? It talks a little bit about how it helps with the pH of the vaginal system, okay? The other thing is you can often recover it from urine cultures and genital cultures as well, okay? On the flip side, bacteremia and endocarditis are known to occur in immunocompromised hosts, so as an opportunistic infection. The systemic infections are pretty rare though, okay? And that's a picture of it right there in purple. Okay, so anaerobic gram-negative bacilli, all are going to be non-spore forming. Often members of endogenous microbiota, those are the different tracts that they're found in. Frequently found in mixed infections or polymicrobial, okay? They're associated a lot of times too with brain abscesses, which is pretty interesting. So anaerobic cocci, again, they're going to be isolated from a wide variety of infections. These, again, associated with polymicrobial infections. And a lot of times they follow orthopedic surgeries for whatever reason. I don't think they have the connection there too good. Okay, this is pretty important when you're talking about collection and transport and processing, okay? So obviously you don't want to prolong it to exposure of oxygen, and you want to transport it as quickly as possible under anaerobic conditions. And usually what happens is there's this thing called like a gas pack. I think I showed you guys that before. It was where the Neisseria was. It's just this big envelope, and they put this little thing in there, and it basically draws out the O2, okay? And then for specimen transport and processing, it's important to avoid what's called shocking. So you really shouldn't put it in the refrigerator, and the amount of time it spends at room temperature should be minimized, okay? So shocking basically will expose them to O2 or permit them to dry out, which is what you don't want to have happen, okay? All right, aspirates have a whole nother different way, okay? So these are going to be collected by needle and syringe, and they're definitely preferred to than swabs. Swabs, you're likely to contaminate it with like what's already there with normal flora versus the aspirate can just basically go in and grab what it needs to grab and you're good to go, okay? Let's see. The aspirate should be injected into an oxygen-free transport tube, and what you want to have in there is PRAS media, okay? And basically how you make this is by boiling and autoclaving, and it replaces any air with O2 with a free gas mixture, okay? So that's what they want to have in the media when they're transporting it. Now, if you're talking about swabs, this is only supposed to be used when it's not possible to get an aspirate, okay? Or if a biopsy specimen is not available, then they'll have to use a swab. Transported anaerobically again, and then on arrival in the lab, this is important, the swab should be placed into 0.5 sterile Thio Fluid. The Thio Fluid is what you guys have seen before. It was in that very first picture. It's the one where the oxygen levels, you can see the differences in the oxygen levels, okay? You can use Amy's liquid as well. Here's a couple pictures of the different transport systems that they have. Tissue, okay? Tissue collected at biopsy or autopsy from usually sterile settings are acceptable, so that's fine. Let's see. The thing about caution must be taken not to tip the container. This could cause heavier than air, and the O2-free gas mixture can be displaced by the room air. That's why they don't want it to tip. The delayed transport, that should be in a pouch containing an oxygen-free atmosphere, okay? And then the process will also include 1 ml of Thio Fluid again. So Thio Fluid is used quite frequently with anaerobes. All right, and then blood. Transported rapidly and incubated at 35 to 37. Very careful collection in terms of like, that's talking about like actually drawing the blood, like for a phlebotomist or whatever, about sterilizing the site before you actually draw, okay? Processing clinical samples. Again, it keeps saying this over and over that it should be immediate, okay? Macroscopic examination of the specimen. We saw the characteristics of the macroscopic examination. Basically, is it acceptable, the foul odor, that type of thing. And then inoculation of appropriate plated and tubed media. You got to make sure your media is correct, okay? Otherwise, your sample is just for nothing. Okay, procedures, when to examine primary plates. Colony morphology and gram staining is pretty important for this. Let's see, rapid tests that they do, these are the list of the rapid tests, which we haven't done many of these, but notice that they have urease in here, and motility would be definitely a good one. I think Lauren had pointed out there, she thought there was Clostridium, was it, on the door handle or whatever, and you were thinking about putting it in Thio Fluid.
Yeah, we did that.
We did do that?
Yeah, and it turned out that it wasn't anaerobic.
Because you could tell from the Thio Fluid.
Yeah.
Yeah.
And in that source.
Right. Okay. So that's another thing that they would be looking at right there too. Okay? And then you can get the presumptive ID from gram-positive anaerobes in such a way. Okay. Problems in susceptibility testing of anaerobes. Reproducibility testing and methodology. That can be a problem because of the lack of reproducibility. Failure of anaerobes to grow in particular media. These guys are so picky, so you have to use particular media, which I just said. And then difficulty in reading endpoints with certain methods. And then there's really hardly anything to compare it to with certain methods. So it's hard to like reproduce plus compare. So you have a couple different problems there when you're trying to look at a culture. Okay? So those would be your main problems with anaerobic isolates. Okay. One last thing, you guys. What I want to go over quickly is bacteremia and sepsis. It shouldn't take that long. It should only take me like 15 minutes at the most. I wanted to make a note that the spirochetes, I don't even know if I'm going to lecture on the spirochetes. You still need to know it, but basically everything is in the PowerPoint for the spirochetes, okay? If you want me to do that, I will do it on Monday, but I think you should be okay without even a lecture on the spirochetes. It's very straightforward, and it's only like 15 slides, okay? All right, so bacteremia and sepsis. So what is bacteremia, anyway? What are we talking about?
Bacteria in the blood.
Just bacteria in the blood, right? So unfortunately, you're often talking about it being associated with hospitalization or insertion of a foreign body, such as like a port for chemo patients or a catheter, that type of thing. Okay? All right. Okay. These are the basic concepts that you need to know. So for these guys, you need to know the definition, and these will be like 2 or 3 questions on the test, multiple choice. Okay? Know too the difference between like septicemia and SIRS or SIRS, which would be an infection with a systemic inflammatory response. Okay? Because sometimes people get those mixed up. But know these definitions because that will definitely be a couple questions on the test. Okay? You do have a classification of bacteremia. You're talking about the site of origin, the causative agent, place of acquisition, and the classification by duration. Okay? Let's see. I don't want to say anything here. Place of acquisition, basically you want to be looking at it, is it community acquired or nosocomial, or did the person just get it randomly from another infection? Okay? Duration, they're going to be looking at procedure and infection, and they're going to be looking if it's a transient, intermediate, or continuous bacteria that's constantly in the bloodstream. So that would be your duration right there. Okay? Epidemiology, incidence and mortality isn't so great for bacteremia and sepsis, particularly sepsis. You have your risk factors right there. Invasive procedures is a big one. I listed, you saw the list of the different bacteria and the percentages there, okay? Age of the patient also plays into this, and is it antimicrobial resistance? What's going on with that as well? Etiology, these are just examples of bacteremia or sepsis, okay? So this is just a slide, you can just look over this one, no big deal here. Pathogenesis, what is the infecting pathogen? They're gonna have to know what's the portal of entry, that's gonna be a big thing. The immune status of the patient, is the patient already in the hospital or not? And then was there disruption of the normal skin or mucosal barriers, okay? I actually did a 2-week rotation at Shands not too long ago in the neurotrauma unit, and it was amazing to see on that floor how many people were septic. It was crazy. So they'd go in for some random neurotrauma brain injury, and then it turns out that they're septic. I would say almost half of them are septic. So that was pretty creepy. And I think most of them got it while they were in the hospital, actually. Okay? All right. Clinical aspects of bacteremia. All right, so catheter-related bloodstream infections, really you're looking at coagulase negative staph, or you're looking at Staph aureus or Anaerococcus, okay? UTIs, that probably accounts for 17% of all bacteremias, which is quite interesting. Pneumonias is about 12%. You're looking at strep pneumoniae, Haemophilus influenza, to give you a few. Intra-abdominal infections, that's only about 5%. And then skin, you're only talking about 2%. Proteus mirabilis is one that actually comes up with the skin a lot, and E. coli, okay? Endocarditis, this is usually caused by transient bacteria, a lot of times from dental procedures or skin infections, okay? Musculoskeletal infections, this would be Staph aureus. And again, this can come from minor skin infections. And then of course you have your central nervous system infections. And on that one, you have so many different things that can happen with that. That's like the worst one to have. And one of the things that sticks out is that there'll be abnormal liver function tests that happen for central nervous system, okay? And you also have the DIC going on as well. So laboratory diagnosis, you have particular specimen collection, so preparing the skin and the blood shouldn't be allowed to clot. SPS are going to be the best tubes for collecting blood for the culture. You're going to have a difference in the density of bacteremia in adults versus neonates. That's something to consider. And then the frequency of bacteremic episodes versus the time and frequency of collection is another one. And then what's your rationale for multiple blood collections? So what is going on there and how often do they need to collect? Okay? This is your list right here of actual blood culture methods. Let's see. Know this list, just basically it will probably be a good short answer question, just what are some blood culture methods for sepsis, okay? And then blood culture systems, These are just examples of blood culture systems, but you don't need to know this. You can even X this out on your PowerPoint. This is just more information, okay? And then treatment, really there's not a lot of treatment, but they're looking at antimicrobial therapy as one, and then anti-sepsis therapy, okay? And those would be your examples of that. But really, a lot of times it ends up being supportive care, unfortunately, for sepsis.